recording. So I'm going to go on mute if everybody would go on mute. Are you guys able to see my shared screen? Okay. It was showing just as only a black screen, and now you can see the slides? Okay. All right. So thanks everyone for joining. Welcome. Apologize for my dog barking in the background. And we were having a bit of technical difficulties. So welcome. So tonight we are going to put on our health webinar series. This is entitled Men's Health, the Forgotten Primary Care. We are the Bluff City Medical Society, and we are going to go ahead and get started on tonight's event. So I will say, if you guys have any questions, please don't hesitate to drop them in the chat, and we'll go ahead and get started. So for housekeeping, we are streaming this live on the Bluff City Medical Society Facebook page. We are also recording this webinar. I will request that you guys take a moment to like, share, and start a watch party to bring more people into this conversation. This recording will be on the Bluff City Medical Society YouTube page and on our website after this event. Again, enter your questions into the Q&A feature and any comments into the chat feature, and we will make sure to get to as many of those questions as possible. And unfortunately, CME is not available for this event. I do want to take an opportunity to recognize our community partners. When we started these community health webinar series back earlier in the year, we engaged a lot of different organizations, and I want to make sure to recognize them appropriately. We have several chapters of Alpha Kappa Alpha Sorority Incorporated, the Memphis Panhellenic Council, Omega Psi Phi Fraternity, Alpha Phi Alpha Fraternity, and the Links Incorporated Memphis chapter. Also, we have to recognize other organizations. So the Memphis Association of Black Journalists have certainly been great community partners for us as far as advertising our events, as well as the Memphis chapter of the National Pharmaceutical Association. We have been very fortunate to have our medical community partners, essentially every healthcare system within the city, as well as University of Tennessee Health Science Center and Church Health Center have also engaged with us to become community partners for this event. So I'm the moderator. I'm Dr. LaTonya Washington. I'm the president of the Bluff City Medical Society. I am internal medicine and pediatrics boarded. I'm currently the physician advisor at St. Francis Hospital, and I'm assistant professor of medicine at University of Tennessee Health Science Center. I do want to take an opportunity to introduce our panelists. I'm very excited about everyone who is joining us tonight on this panel. So we will go ahead and get started. So Dr. Persico Wofford, he is internal medicine and nephrology. He's a Mississippi native, is a graduate of UMC, please pardon the typo, that was my fault. And he completed internal medicine residency at Methodist University Hospital. He was chief resident, did his nephrology fellowship at University of Mississippi Medical Center, and is board certified in both internal medicine and nephrology. Our next panelist is Dr. Fred Kency Jr. He is board certified in emergency medicine. He's also a Mississippi native. He's a graduate of Alcorn State University, got his medical degree from University of South Alabama. He's a Navy veteran. He completed his emergency medicine residency at University of Mississippi Medical Center and is assistant professor of emergency medicine at University of Mississippi Medical Center. Dr. Deaunte Thompson, he's a California native, went to Loyola Marymount University for his bachelor's degree. He's a graduate of Meharry Medical College, and he currently serves as the medical director of the Baptist Memorial Hospital Crittenden in West Memphis, Arkansas. And then Dr. Walter Rayford, also a Mississippi native. He's a Jackson State University graduate. He received his PhD in biochemistry from University of Kansas, as well as his medical degree. And he also has an MBA from University of Tennessee. He completed his urology residency at University of Kansas, and he is board certified in urology. So that is our lineup for this evening. So I am going to stop my screen share, and then we will go ahead and get into our discussion. So thank you for joining us, gentlemen. I am excited about this conversation. So let's just start the conversation off with the reason that men's health is important. I mean, we know from the data that's out there that the life expectancy of men is about 6 years shorter than that of women. Also, we know that life expectancy has certainly been affected during the current pandemic, and so that those numbers are reduced even further, particularly in communities of color. Can you guys give us a little bit of comments about that and about your viewpoints on men's health and why it's so important?
Hey, how you doing? I'm Dr. Kency. Like you said, men's health is, especially African-American men's health is very, very important. Knowing that we have some of the poorest health outcomes in addition to the lowest life expectancies, a lot of that is based on just the lack of education and the lack of advocacy to get some of our Black males into clinics, into visits with physicians so that we can have them have better outcomes. That's really what it comes down to. The sooner we're able to get our males in with doctors to find these different preventive medicine type of problems, the longer we're gonna keep guys like us around. And I think that's what all of us are here to advocate for.
And so talk to us a little bit about some men feel that seeking out healthcare or letting them know that they have a health issue is a sign of weakness. And how can you guys comment on that?
I'll try to answer that question. I think men have traditionally been the breadwinners of the family growing up in a traditional family household. And I think they're, for some reason, got there ingrained in themselves that they're providers almost at any cost. Work, rain, sleet, or snow to help provide for their family and take care of the family and their needs. And some have, lost along the way taking care of themselves because they always taking care of their family as their priority, and seem to lack, or lose sight of that. In order for them to take care of their family, they got to be healthy themselves. So that's one issue. Another issue is that for some reason, a huge portion of Black men, and especially in the South, don't want to go to physicians for whatever reason. They rather not know what's going on. As long as they feel well, they don't buy into a lot of preventive medicine. So that's another issue. Another issue is a lot of times, depending where you are, I practice in Whitehaven and see patients. A lot of them don't have adequate access to care. I grew up in rural North Mississippi, so access to care is limited also in the rural America, especially in our state and our region. So that's three factors, but I think education is going to be key, and also influence of other family members, because we oftentimes, when a male does come to the office, almost have to be dragged in by his significant other to the office to get treated, or he wait till something really bad happens, or he's hurt in pain, go to the emergency room, and because he oftentimes ignoring the warning signs and symptoms that he has, and then when he presents the condition at more advanced stage, and then that also, despite treatment, if it's an advanced stage, also leads to worsened outcomes long term and shortened life expectancy. I'll stop at that.
So let me take a stab at that, Dr. Washington. When I first started my training in Kansas City, 2 or 3 years ago, of course, I was absolutely amazed at, and this was during the time when prostate cancer screening was becoming in vogue. And I was absolutely amazed that in many of the published reports, that most of the participants were Caucasian. And this is despite the fact that the screening location occurred in cities that had a large percentage of African-American patients. For this instance, let's say St. Louis. Right across the river from St. Louis is East St. Louis, which is 95% African-American. I always wondered why those sites had such low screening participation. So when I took my first job out of training in New Orleans, at the time, New Orleans was 70% African American. And in the screening program that they had there at LSU, they only had 20% African American participation. So when I took over the screening program, we made a concerted effort to, one, educate men about the importance of prostate cancer screening and men's health. And we had an intense effort to reach these men. That our results quickly reflected the demographics of the city. In other words, within 1 or 2 years, our demographics had converted from only 20% African American participation to up to 70%. And I think the primary reason because we made a concerted effort to reach those men. And in that concerted effort, it was not a one-time per year event. And if we are going to be serious about men's health, we can't just focus on men's health during Men's Health Week. We have to have a sustained program that highlights the importance of men's health throughout the year. If we look at women's health, there's always something going on about women's health, and we don't have that about men. And the key, as what Dr. Kency and both Dr. Wofford have emphasized, is education. And part of that education, or the majority of that education, we as physicians, we must do if we want to see the trends change to more favorable outcomes for men of color.
I absolutely agree with that. And I think that, for a lot of men, their first touch point into the healthcare system is emergency medicine. I know both Dr. Thompson and Dr. Kency are emergency medicine. And so can both of you kind of give us a little bit of input as far as what are some of the tactics that you utilize when you're encountering men in the emergency setting to kind of get them plugged in or encourage them to seek primary care?
So what I've noticed, what I've learned, what I've tried is that it's always good to kind of attach a family member to it, whether it be the wife or the daughter. Because like one of the gentlemen said, a lot of times that when they do come to the hospital, not coming by themselves, somebody has dragged them to the hospital. So if you could start to educate that family member, let them know how important it is, and tag on, if you love dad, you love your grandfather, it's very, very important for you to bring them into the hospital so you can get these annual checks. From my experience, when I've just sat and I've just spoke with grandfather, with dad, a lot of times they say, yeah, but a lot of times it doesn't happen. So you really need that extra person to kind of push them along and guide them along the way. And I guess one of the, a solution or an idea to when it comes to, only talking about men's health, once a year, I guess one thing that we could do is kind of attach that with women's health, because a lot of men will follow their wives or their daughters. And so, you could, attach it with children. A lot of, grandkids, they could bring their grandfather along when they're coming to get tested and stuff. So instead of just doing it once specifically for men's health, you do it a little bit along the way while we're educating others about their health.
Yeah, a lot of times it's just asking the right questions. I have patients all the time. Obviously, it's emergency medicine, so the patients vary in their problems. I have patients all the time that come in for ankle pain, they come in for knee pain. And when you're in pain, sometimes your blood pressure is going to be a little bit higher than what it normally runs at home, right? But I'm always asking, well, do you have a primary care doctor? Do you check this normally? If they tell me no, sometimes I'll say, do you mind if I get a finger stick to make sure that you don't have diabetes? Because if they're not seeing a primary care doctor regularly, then they could have uncontrolled or, mildly elevated glucoses that could be putting them at risk for diabetes in the future, especially people who I see are either obese or have answered yes to smoking. I usually will almost always ask them, do you mind if I check it? Some of them say no. A lot of them say, sure, why not? And luckily in our state, in Mississippi, we have, especially in Jackson, we have this thing called the Jackson-Hines Comprehensive Medical Center, where it's a federally funded kind of a quality health location where your cost of going to this location is pretty much based on how much money you make. So if you don't make a lot of money, then you don't pay hardly anything. And this is something that I went to when I was a child. So it's been around a long time. I've had teeth pulled there. I have family members who got blood pressure and diabetes medications at that location. And I'm a huge advocate for sending people there that don't have insurance, because that's a lot of times their biggest reason. I don't say excuse, but because it's a valid reason. I don't have the funds. It's not free to go to a doctor appointment. And so I tell them, hey, you go down to the Jackson-Hines Comprehensive, give them a call, get an appointment. They can give you blood pressure medication. Sometimes you'll pay less for the clinic visit than you'll pay for your blood pressure pill when you get to Walmart. I mean, it's kind of hard not to be okay with that, And so I'm talking, 2 hours out of your day, maybe $12 out of your pocket, and you could add 10 years to your life. You just try to put it into numbers, hey, adding years to life, taking this one pill can add years to life. It keeps you around longer for your wife, around longer for your family. Those kind of things have seem to work. Those who do have insurance, obviously you don't want to bog down that system with people who already have insurance. So I do send those people to some of the providers in our network. I have a great relationship with internal medicine and pediatrics, as well as family medicine within our network of very trustworthy female and male Black primary care physicians. And my wife is also a primary care physician. She did medicine and pediatrics as well at our hospital down the street. So, the biggest thing I've found to work is the education portion. Hey, if you don't get this under control, you could have a stroke, you could have a heart attack, you could not be around for your daughter's graduation from high school. And then letting them know that there's ways where these things aren't as expensive, which has to be 80% of the verbalized barrier that they always say, well, it just costs so much. Well, it costs a lot less than a heart attack. I promise you. I've seen those bills when they go home, and I promise you that hydrochlorothiazide costs a lot less than a trip to the ER.
Yeah, absolutely. So I do want to kind of, I was going to plan to kind of shift into this portion of the talk later on, but I know Dr. Rayford has another engagement. And so since he is the urologist who is on the line, I did want to talk a little bit more about kind of some specific men's health issues. So prostate cancer. I know Dr. Rayford, you talked about that a little bit before. So can you just kind of go over the current guidelines as far as screening for prostate cancer and the increased risk for if there's a positive family history, and talk to us a little bit about that?
Sure. So prostate cancer is, and for a long time, is the most common malignancy in the American male. And this year, close to 250,000 men will be diagnosed with prostate cancer. This year, almost 34,000 men are anticipated to die from this disease. Unfortunately, African Americans have a significantly higher incidence of prostate cancer than any of our ethnic counterparts. And the mortality rate from even our closest ethnic counterpart is African Americans have twice the mortality rate. There are, for the most part, we really don't understand what causes prostate cancer, but there are some things that increases one's risk of developing prostate cancer. Those things, as I just mentioned, one, being an African American. Secondly, age. As we grow older, our chances of developing prostate cancer increases. There's about a 1 in 8% chance that that we will be diagnosed, that our African or that a male will be diagnosed with prostate cancer in their lifetime. And thirdly, family history. The more first-degree relatives a person has, the higher their risk of developing prostate cancer. First degree defined as father, grandfather, or brother. With respect to screening, there are a number of screening guidelines out there. There's American Cancer Society guidelines. There's the American Urological Association guidelines. There's the National Comprehensive Cancer Network guidelines. There's even guidelines from the predominantly African American Urology Group, which is R. Frank Jones Urological Society. And all 4 groups have different guidelines. So I'll just focus on one guideline, which probably more people are familiar with, and that's the American Cancer Society guidelines. The guidelines for prostate cancer screening include if a male has a general risk of developing prostate cancer. And what that means is if you're a Caucasian male without a family history of prostate cancer, then you should start prostate cancer screening at the age of 50. If the risk is increased, which means that if you're an African American person, or if you have a first degree family relative with prostate cancer, then you should talk with your physician and begin the screening process at the age of 45. If you have a higher risk, and that is if you have more than one first relative with prostate cancer, and this person was diagnosed with prostate cancer, or these people were diagnosed with prostate cancer at early ages, then you should start prostate cancer screening at the age of 40. The predominantly, or the African American Urology Society recommends prostate cancer screening for all African American men, regardless of their family history, to begin at the age of 40. Now, what is an elevated PSA? Well, what's the screening? Well, the screening should consist of at least 2 tests. One is the blood test, which many people are familiar with, which is called PSA, prostate specific antigen, which is a protein that's predominantly secreted by the prostate gland. And the higher the levels of PSA in the bloodstream, the greater the chances are having prostate cancer. The other test is the 1 or 2-digit rectal examination, depends on your urologist. Just kidding about the 2-digit. Loosen up just a little bit. But the combination is recommended for prostate cancer screening. And interestingly, if a person who starts screening and their PSA level is less than 1, then the recommendation is you can participate in screening every other year. But if your PSA is greater than 1, then annual recommendations, annual prostate cancer screenings are recommended.
Thank you for that. I mean, I certainly think that for a lot of men and for those who are listening in on us today, I certainly appreciate getting that information from you. And then before you hop off the line, I do want to make sure that we do talk a little bit about other men's health concerns, particularly things such as erectile dysfunction. Can you give us a little bit of overview on that? I can like turn my camera off and mute my line, kind of disappear for a minute, because I know that a lot of men are not comfortable talking about this around women. And so sometimes as a female physician, we have a little bit of difficulty getting men to open up about this issue.
Most men who won't help don't care who's listening to or who they're talking to. So, erectile dysfunction increases with age. And there are a number of things that increase one's chances of experiencing erectile dysfunction. Erectile dysfunction is defined as the inability to obtain or maintain an erection for satisfactory intercourse. Now, the key is satisfactory. And that definition may differ from one person to another. But some of the risk factors associated with erectile dysfunction include hypertension, medications to treat high blood pressure, diabetes, coronary artery disease or peripheral vascular disease, smoking, increased alcohol intake, stress, and fortunately, there are a number of treatment options. Oh, let me also say surgery, because certain surgical procedures can lead to erectile dysfunction. There are a number of options for treatment of erectile dysfunction. The first line of treatment usually includes oral medications. And there are a number of medications that are used to treat erectile dysfunction. Viagra, Cialis, Levitra, Staxin, Stendra, and now they have generic forms of Viagra, Levitra, and Cialis. So essentially, there are at least 8 different pills that a person can take that can help them obtain and achieve an erection. Critically important to taking these medications are taking these medications following the right instructions. 3 basic things that men have to take in consideration when they're taking these medications. 1, they have to take them 30 minutes to an hour before they engage in intercourse. Secondly, it's best if they take these medications on an empty stomach. And thirdly, they must have some type of physical stimulation. And the older men get, the less likely they are to participate in the physical stimulation. Most men just want to, forget about all the talking. Let's just get down to business and call it quits and let's go to sleep. So, but we have to emphasize that they have to have some physical stimulation. Now, what happens if oral medications don't work? There are a number of other options that men can use. One, there's a vacuum erection device, which is a cylinder that a man places his penis into. Press a button, and a cylinder will create a vacuum. Vacuum helps blood to flow into the capillaries of the penis. And once engorgement occurs at a satisfactory amount, it releases a ring. The ring is released at the base of the penis. It keeps the blood in the penis, allows men to enjoy intercourse. And then when they're done, 2 hours later, then they can take the ring off. Now, I got a smile from all the guys. I don't know if the girls are listening, but all the guys are smiling. Now, there's something called combination therapy. Combination therapy is using an oral agent with the vacuum erection device. And one gets a better response using the combination of treatment as opposed to one or the other. Other options include, there's a medication that a man can insert into the tip of the penis. It's a little pellet. The pellet facilitates blood flow into the penis. And about 15 to 20 minutes later, the penis becomes erect. If those options don't work, there's medication that men can inject into the side of the penis. And that medication usually works within, 5 to 10 minutes. And then if all of those fail, then surgical treatments are available with placement of what's referred to as an inflatable penile prosthesis. So there are a lot of options for men who experience erectile dysfunction. And the important thing to realize is that if a person experiences this condition, it does not mean that's the end of their sexual life. There are a number of options that they can use for them to continue to engage in this very, very important aspect of living. Having said that, unfortunately, I have to get off and go to another meeting. So thank you very much for the opportunity to participate in this session. And I'm certain that my colleagues, Dr. Wofford, Dr. Kency, and Dr. Thompson, will continue to engage the audience about men's health with a special focus on African-American men.
Thank you, Dr. Rayford. I appreciate you joining us this evening. And I will say that I learned something by listening to you. There were a few things that you mentioned that I didn't know about. So thank you.
Jokes?
I mean, the jokes too, they were good, funny. You should take that on the road.
Thanks a lot. See you later.
Thank you.
Thank you.
Thank you.
Like Dr. Rayford was saying, I can honestly say from experience, men have become much more likely to speak with even female providers, physicians, about their sexual health stuff. My wife, like I said, is a primary care physician, and her patients have no problem bringing all the information, questions to her, which huge difference from even just 10, 12 years ago when we were medical students, where that just wasn't the same thing. And then I went to medical school in Alabama, so pretty much the same population. So.
Yeah, that's a great point. We actually had a question that was posted in our Q&A feature, and it talks about one of our listeners asked, how does the low number of Black men in medicine impact the health of Black men as a whole? Do you feel that most Black men don't go to the doctor because they feel as though the doctor may not be able to relate to that? So can you guys comment on that?
I think
I know a lot of, I'll let you go.
I definitely think it plays a part in it. A lot of times patients do feel more comfortable with somebody who looks like them, who can share experiences. The amount of, I mean, I don't remember that's exactly, but I do believe that Black men are a little than everyone else, but we are rising. Well, once again, I think that it's more important to find that person you can identify with, you can connect with, and it really doesn't matter what color they are, as long as they're able to listen to you and answer your questions and help you.
I think Dr. Thompson, I think your connection kind of froze on us, but certainly we got the gist of your comment. I want to kind of take an opportunity and shift, and we'll kind of go back to more of the preventive care. So gentlemen, can you guys talk about just the importance of routine health maintenance for men, and like things they should look for, healthy weight, and then talk a little bit about the screenings. I know Dr. Rayford talked about the prostate screening, But, there are other screenings that men should routinely undergo, women as well, but men also.
I would start out as an internist, and also a nephrologist. Uh, Basically, if you're African American male and all males, you have uh, an annual checkup, and that's an opportunity when they see their physician. The physician can discuss things like safety, seat belts, smoking cessation, in regards, and other things, alcohol use, intake, or abuse, depression screening. That's very common in an outpatient setting in primary care. Uh, High blood pressure screening. Uh, if you're at appropriate age, screening for cholesterol, because we know as the older we are, your 10-year risk of cardiac events goes up, especially if you already have underlying conditions. And so you check your cholesterol, check your blood pressure. Uh, as part of a lot of, part of the annual exam. If you're over 65, thyroid screening. Uh, and those are just some of the screenings. And now moving on to cancer screening, uh, colon cancer screening. If you're 45 and African American, you need to be screened. Uh, some of the new guidelines. I forgot which particular administration organization said 45, but it's not 50 anymore for African Americans. It's 45. So cancer screening. All this can be done at annual exam, and not to take all the time, but some other things that the intern look at. Have you had your flu shot? Have you had your pneumonia shot? Are you up to date on your vaccinations? Diphtheria, pertussis, shingles. So there's a myriad of things that can be done once you go to that office of your primary care. And like I said, I don't want to take all the time, but I think that's an excellent opportunity to range from vaccines to cancer screening to screening to decrease our cardiovascular risks. As we know, we die of cardiovascular disease, so blood pressure, cholesterol, other things like factors like thyroid. So there's a lot of things can be done once we get you in the door. And as we said earlier, that can put years on your life. So I think I'll yield back the rest of my time to other panelists.
Sound like the congressman. I yield back my time. I like it. But yeah, as an internist, obviously he has the most dedicated education to knowing preventive care and, things like that. But another big one that people, miss out on, and I tell them all the time because we see them in the ER because they don't go to their primary care doctors, is the STD checks, checking for HIV, checking for syphilis, checking for those things that hide, that you don't see, that have no symptoms, things like chlamydia in men. Typically gonorrhea in men will have some symptoms, but chlamydia can go for long times without treatment. And men never know it until they get, things like epididymitis, and so that causes them actual pain. Things like, just basic EKGs to see that, make sure that you don't have any weird tachydysrhythmias like atrial fib that puts you at risk for strokes in the future. And I'm always so surprised when men come to my ER and I ask them, well, do you have a primary care doctor? Do you go to an annual visit with your physician? Well, I don't have one. Those visits are too expensive. I promise you, the expense one is the most commonly used excuse. And I tell them, well, since Obamacare, you don't pay for preventive medicine visits. Those visits are not supposed to be charged. That is given to you through your insurer. And most of them don't even know that. They don't know that one visit a year is not supposed to be taxing. And so they should be testing for your diabetes, checking your cholesterol, checking your blood pressure, checking your weight, all these important things that can add years to your life. And then once you tell them that, like, oh, I get a free visit every year, like, yes, that's your visit. Go do it. I mean, your company is already paying for this benefit. go take advantage of it. And that's one thing that can usually stimulate them to actually go and actually get a primary care doctor too. So.
Yeah, I think that's a great point. And then, you know, they are seeing you in the emergency room. And so whether they have insurance or no insurance, all visits to the ER are costing the individual something. And certainly it's more expensive than going to see someone in the office, even if they did, you know, have an issue where that wasn't preventive care for them to go to the office. So we do have a couple of questions in the comments. I think one of the ones that we, you know, kind of touched on a little bit, I know Dr. Wofford mentioned about the depression screening. And so one of the attendees had a question about Black men and mental health counseling choices. I know that with the Bluff City Medical Society, we had a mental health webinar back a few months ago. And just looking at the demographics of the individuals who signed up for that event, it certainly was a predominance of women that signed up for the event. And so let's talk a little bit about mental health and men, and Black men in particular. So I'll yield to you guys to give a little bit of information about that and your thoughts about mental health.
I think there's a couple, there's sides to mental health, right? So you have the side of like overactive, like ADHD. In men, I found that it's not very hard to get those guys treatment. Ones who, you know, in the high school age, college age, think they have ADHD. It's not hard to get those guys into treatment. Hey, something's going on. I think if you get this treated, you may actually do better in school. You may be able to focus better. You may have a better relationship with people around you. Whereas you have those other diagnoses that carry a very negative stigmata, things like depression, things like schizophrenia, things like obsessive use disorder type things. So when you speak to that side of it, it's tough. It's tough to get these people to truly go and do treatment, because treatment comes in twofold for most of these mental health stigmatas. You have the medication, which nobody wants to take, right? And then you have the psycho counseling that goes with it, which statistically is going to do them more benefit than the medication. But every patient just wants the drug. If I can, well, just give me the drug and let's see how it works. Well, it's a two-part thing. You need both. Like, you know, you can't cook eggs without a skillet and the fire. You need, you got to have both of them to get it done. And so, and to the question of seeking the actual counseling and what are the choices, and it's really state dependent, you know, and I've been in Alabama, I've been in California, I've been here in Mississippi for some time. We have state run, we call it Region Health, Region 9, and each, there are different numbers by different areas in the state. So Region 7, Region 6, Region 9. Here in our city is Region 9. And we have different accesses for the psychotherapy. That's the part that we can readily give people without a problem. The issue here becomes the actual psychiatry portion, becomes those who need medications. And we know that you need both, right? You need the medicine and the psychotherapy. So getting them into physician offices, into psychiatrists' offices to get them the medications when they need it becomes the true barrier, at least in our, down here in Mississippi.
Yeah, I will also comment on that. I did want to let everyone know, I did drop in the chat with the Bluff City, when we did the mental health webinar, we did have a mental health resources that's linked on our website. I dropped the link to that in the chat. And so those are mental health resources that are available in the Memphis area. It also lists psychiatrists and counselors that you can reach out to be able to access those services. One of the challenges that they talked about during that webinar when we were talking to 3 psychiatrists was the difficulty in finding providers that are able to provide culturally competent care. And so sometimes that's a bit of a challenge with men, I would say men in general, seeking mental health services. Any comments on that at all?
I often get calls from other physicians trying to identify African American psychiatrist. So I think in a lot of ways there is a big concern. I grew up in rural Northeast Mississippi, and from my perspective, I'm just going back and uh, there's a big stigma from African Americans and mental disease, especially with men. Uh, Most people, and it's almost like a stereotype that the crazy uncle that's in the closet or in the room by himself who really has schizophrenia that's untreated for years that the family kind of ignored. Those are things and stigmas and myths that we got to dispel and try to get those patients, people the help that they need. So I think we're just doing seminars and things like this, webinars, trying to educate the public that there's something wrong with Uncle Johnny, Uncle Buck, instead of, saying he just off. I think that's one of the things that we got a barrier from the beginning, that from the house before they even get to us, get to somebody who can offer some treatment. Then once we get them there, and we find what's wrong, offering the treatment, then we can also say who's the best. Are they going to get the best care from this provider across town, or do I got to seek out somebody else, or do I got to send them somewhere else to get the best care? So there are sometimes, some barriers even before they get to us that we got to overcome. I think that's continued to be a struggle, and I think people have heard those comments and things like that by their relatives. But in my experience, I think a lot of African Americans won't be treated by African Americans. I think that's one of the things that we should be able to offer those services and try to provide those services, and because those providers and physicians, African American, or better relate to that experience of that patient going through. I say they're not getting good care, but a lot of times they're not. Other races may not be as sensitive or culturally aware of the African American patient in some regards.
I totally agree with what you just said, Dr. Wofford. One thing that I've noticed is that we can definitely get the patients lined up for treatment, and they can get the medicine, but it's just to get some of the patients to take the medicine. And I think that's where it comes back to, where it's education to not just to the patient, but also to the family members too, so that they could take part and partner with the provider who's taking care of the patient, and get them to understand how important it is to take the medication, so that they won't have these relapses every 6 to 12 months, or sometimes even every 2 to 3 months.
Yeah, that's so important. And I think that also, you guys kind of touched on it earlier. We talked a little bit about family history. And so Dr. Wofford talked about, the uncle that they were saying was just kind of off, but really has mental illness. And so it's important to know that down the line, because that may increase your risk for mental illness or increase your child's risk for mental illness, and making sure that those diagnoses are made appropriately, so that, when you start seeing kind of signs and symptoms, that we can get those individuals plugged in quickly so that they can get the care that they need as well. Okay, so also, Dr. Wofford, you talked a little bit about kind of health maintenance. You talked a little bit about vaccines. So, we cannot talk now during a global pandemic about vaccines and not bring up the COVID vaccine. And so one of the things that we have been looking at here in the Memphis metropolitan area in Shelby County, is the number of individuals who are actually vaccinated against COVID. And so right now we're really sitting at about 34% of individuals in Shelby County who've been vaccinated. I know for you, Dr. Kency, in Mississippi, it's our home state, but they always struggle. And so I think the overall vaccination rate for the entire state is sitting at less than 30% of individuals in the state that have been vaccinated. So any comments on how we can kind of get Black men in particular to get vaccinated, and why they may be at increased risk for COVID as opposed to some other people groups?
I think it's gonna be a huge challenge. Personally, I went to a funeral and I saw a lot of people in the church. It was a mask. A lot of people wasn't wearing masks. Uh, Fortunately, my family member who, his wife died, you know, he was already vaccinated. But I'm afraid a lot were not. Even some close family members, a brother of mine, be personal, he said he doesn't get sick. He doesn't, he didn't, I talked to him about it. He didn't think he needs it. And I think it's gonna be a huge challenge to educate the population, and because I fear the worst, because yes, in my own personal view, I've seen 2 people die in the last couple of weeks I took care of with kidney disease and COVID, both in their 70s. Uh, they died. And I have another patient, my office patient, he's 69, 70. And I think all 3 were not vaccinated. So I think, we'll get more and more of illness and from unvaccinated, which is we see now going to be the predominant people coming in ill and sick enough to come in the hospital and going to be dying are the mostly going to be unvaccinated populations. How do we get to those populations? One of our colleagues we talked to was on a call for state volunteer. He was at a conference in Florida. I'm gonna have to wait to see what he got, because there was the whole thing about why are people hesitant. I talked to a nurse, which I consider a friend. I knew her for a long time, and she's hesitant, even though she's treating patients with COVID. So I know it's a men focus, but why is the hesitancy? It probably multiple layers on that. But I'll tell you one last story and move on. I had a patient, 35 years old, morbidly obese, on dialysis, so he has comorbidities, and he had it and had respiratory failure and almost intubated, and he survived it. He's still on oxygen, so he still got long-term effects. But now he's really take his COVID vaccine. And I guess I'm going to spend more time and figure why now? Why the change now? So we know the devastation of this disease. If it doesn't kill you, it's going to be severely debilitate you and disable you. We've been knowing that. I guess the question that I can figure out if I get to him and try to get root cause analysis and say, why change now? And then use that information to go back and spread it to the other section of the population who are hesitant or think they're not going to get sick. So we got to do more than just say, you need it, you need it, you need it. We need to say why you need it and figure out why they're resisting, and dispel the myths of the microchips and all this type of stuff. So I think we're kind of, unfortunately, I'm going to be a pessimist. I think it'll be tough times ahead for African American men and African Americans, which are a huge portion of the population who are non-vaccinated, especially back, I went back to my hometown. So I think we got to get root cause analysis, try different things, and figure out why they're resisting, and don't wait. Because I think the longer we wait, the thing is worse we're going to be long term for this population. So I don't have the answers. I'm willing to, be part of the solution and do what we can, because I think, for our race, I think we already been devastated, and we're also devastated by common diseases, and this is a pandemic. And then I work in a majority Black part of the city, African Americans I see, and we're dying of this devastating disease. So I don't have all the answers, but I think we got to address the issues, and whoever comes up with the greatest idea, we need to try and try to get as much more people vaccinated as possible.
Yeah, to echo on what he was saying, a huge portion of the folks that we see in the ER, when you ask them, why haven't you been vaccinated? Because that's a common question I ask people in my ER. Even if they don't come in for COVID, I always ask them, have you been vaccinated? Blah, blah, blah. And a lot of times, your answers, especially for the younger males, is that I don't think it's going to hurt me if I get it. It's not going to kill me. If I get it, it's kind of like the flu. And so there's still this this stigmata that it's not a deadly thing to them. Another one is, I think that a lot of the ones who have not been vaccinated, kind of like he was saying, they haven't firsthand experienced either a direct relative or a loved one that's actually suffered through COVID. And not just the ones who suffer through it, some of those long haulers that we have who tested positive for COVID, had an ICU stay back in January, and now it's June and they're in nursing homes with peg tubes. And these were people who were walking around paying their own bills, cooking their own food. Those people who have seen that in firsthand, a lot of those folks they were able to change their minds because they saw how that 40-year-old cousin who was totally independent, lived on its own, did all of his own everything, now is in a nursing home. It's like, well, I don't want to be him. And so that changes some minds, but we don't want to put that on people. I don't want more people's family members to go through anything like that. But that seems like what it's taking to get people to do it. Should we have some PSAs from people who are COVID long haulers who have had it and gone through it, and now they're on a trach or have a peg tube or in a nursing home, and other people have to wipe their booties for them? Like, do we need those people to create PSAs in order to get people to get vaccinated? I think so. I think that's probably going to be one of the things coming down the pipeline through a couple of different organizations, is actually getting some of these people who have had to deal with these long issues from COVID, whether it be continued shortness of breath, whether it be pulmonary embolisms after COVID months down the road, whether it be developing myocarditis in a person's child. I had a friend of ours whose son had the child COVID severe one, the MISC, and our hospitals down here have been devastated in our ICUs, the pediatric ICUs, from children who have gotten COVID. And I know for sure that has motivated some people that I know to get their COVID vaccine when they see that someone else's child had such a tough course. And like, well, I don't want my child to go through that. So things like when it directly affects you, you're more likely to take a little bit more proactive stance to prevent it. But until then, some of these people just, it's going to be resistive, and we're just going to have to keep on educating and doing webinars like we're doing and show them that I got my Pfizer in December. When the first day they said it was available, I was the first one to the door.
Exactly.
Yeah.
Exactly. I do want to also state that, so in our COVID webinar, we had a COVID themed webinar last month. I did drop the link in the chat feature. We actually had one of our panelists on that webinar that was a COVID survivor. He was a gentleman that had COVID back in early March, April 2020, I believe, and was in the hospital for like 2 months in the ICU on the ventilator. Got out of the hospital, then ended up developing sepsis and endocarditis, had to have a valve replacement, so open heart surgery and valve replacement, and he's doing well now, but certainly that was a very long course from an illness such as COVID. And then I was also on the Memphis and Shelby County Task Force meeting today, and they reported that in Memphis and Shelby County, 30% of the COVID cases over the past 14 days have been children under the age of 12. And so certainly that is a risk. And they say that that group is the largest group of individuals who are getting COVID. So while we're talking about COVID, we're talking about men's health. And so it's important that everyone in the household is being kept safe, because we know that COVID can affect everyone. So maybe it's dad or granddad that's going outside of the home to work and the one that's being exposed to COVID. And even though he may or may not have symptoms, but he can come home and spread that to the children, and they could get really sick. Or vice versa. So, certainly that's something that's really, really important. We did have a couple more questions in the Q&A. So one of the questions was about low testosterone. It says, how commonly are Black men coming to their doctor to discuss low testosterone? What are some of the benefits of supplementation if an individual does have low testosterone? Any comments on that, gentlemen?
As an ER doc, I don't see a whole lot of guys coming to ask me about low testosterone, but I can say when I did do primary care doctor stuff in the military, the few gentlemen I had that came in for low testosterone, when the lab work all came back, they actually, the majority of them actually had thyroid problems and not testosterone problems. Their testosterone was fine, and it was them having low thyroid actually was their issue. But I'm pretty sure Dr. Wofford can give us a lot more knowledge on that.
I'll try to broach it. I think a lot of times men feel fatigued or menopause, male menopause, or menopause type symptom. They just don't feel like they have the energy they have, and they might contribute it to low T until it's checked and evaluated. So at some point it got to be checked and then screened and say, is it low or not? And at that time, you get, perfect time to see, as interns, you always figure out what could be if it's not low T. So that's when the thyroid and these other illnesses, do you have diabetes or that's been undiagnosed or whatever else is going on? Are you anemic? That's why you don't have the energy for whatever reason. So that's be an excellent time to do the internist differential diagnosis thing and figure out what's going on. Specifically in low T, if your testosterone is low, you gotta really be careful and talk about the benefits and the different modalities, whether it's an injection or it's some kind of cream replacement, and also they need to be monitored when it be replaced. Because a lot of times these testosterone can increase cholesterol. And if you already got underlying other health conditions and higher cholesterol, then that increases your cardiovascular risk. So I know Dr. Rayford treats it all the time. I treat it, and I have patients from time to time also, but they treat it and they also check a lot of cholesterol. We have mutual patients, and some patient he won't treat until their cholesterol is controlled. But men, they'll do what's best for them, meaning that if you need, the vigor, you lost your vigor and your stamina and you're, feeling of being a man, they'll take the testosterone, but they won't take the cholesterol medicine. So that way, astute physician would check this out and say, hey, we can't keep doing this. So we'll stop the therapy until you get on board. Otherwise, you won't get treated. So I've seen that happen with mutual patients that we have all the time because these things have side effects. Too much steroid, it's not good. They have adverse effects. And it got to be monitored and treated just like any other drug. You got to monitor for side effects and the risk benefits of all these things and taking into account when you're seeing somebody with low testosterone. Definitely they do benefit, but you also got to monitor them and watch out for any side effects they may have. And also, decrease their cardiovascular risk and risk for thromboembolism and all this, these other things that maybe go along with treating testosterone replacement. So
yeah, I definitely agree with that. I will say that in my experience, I've seen a couple of patients that presented to the hospital with, that were fairly young patients under the age of 40 with what one would think would be relatively low risk factors that came in with a heart attack. And then when you talk to them about it, they said they were taking testosterone supplements. And so we know that that is a risk factor. And, they didn't initially report that as one of their medications. It's like they go to, kind of these clinics and they'll, someone will prescribe or give them this testosterone, but they don't really recognize it as a medication, as a therapy. And so sometimes it might be missed, but this guy had, low risk factors. We checked his cholesterol was normal, but he came in with a heart attack from the testosterone supplementation. So
they'll order it from around the country too. Like I've seen where they order these medications, whether it be Viagra because they don't want to go to a doctor, or testosterone gels or tablets or patches. They'll order them from Canada or from Mexico, and you don't know what you're getting. I mean, it could be anything in those tablets and those gels that could be affecting your health negatively.
Yeah, actually, I was in Mexico a couple of weekends ago, and they had so many pharmacies that you could just walk in and buy Augmentin, Zithromax, and everything that you want. So you have to really be careful. It's definitely not regulated like it is regulated here in the U.S.
I think one thing I add is that there's probably a stigma also, because a lot of men may not want you to know they need to take something to keep them strong and vigorous, so to keep their, keep them, but the vitality and keep them strong. They might not want the bulge. They're taking, I need to take testosterone to keep me up, keep me feeling like a man. I think a lot of that is maybe going on why they don't necessarily divulge it all the time, especially if they're getting it outside of a physician or going to a clinic where they're not getting regular physical exams and checks while you're on it.
Yeah, definitely agree. We have another question in the Q&A from one of our attendees that says that they recently had a gastric bypass revision, and they talked about the number of Black women who opted for the procedure really greatly outnumbers the Black men who had the procedures. And how could awareness of the benefits of a weight loss surgery be shared to more Black men to assist them in their weight loss efforts?
I have one of my good friends, actually a couple of my good friends have had gastric weight loss surgery, and almost all of them asked me about it prior to doing it. And if you go on Instagram, there's a hashtag VGS. It stands for vertical gastric sleeve. And it is a huge community of, a lot of African Americans who have had the procedure done and have had amazing results from it. Obviously, whenever you go under the knife, it comes with risk, so, make that decision, under the consultation of your physician prior to going to a surgeon who's going to be profiting from this. But I feel like, honestly, in my personal experience, which is a, N of less than 50, the men, sometimes it's more of a financial thing, because the men are sometimes the breadwinners of the family. So if they have to take off 2 weeks, 3 weeks, 4 weeks for a surgery, there's a lot of times they're just less likely to do it. I mean, I hate to have money be the answer for every question, but a lot of times that's what it comes back to. But in the men who have done it, they have had really good results. And I do push it to a lot of my patients who I see who are, super morbidly obese, not the guys who are, BMI of 30, because I'm a big guy myself. So obviously I probably should be watching what I eat a lot more too, but those gentlemen who come in and their weights in the 400s and the 450s, I usually will have that discussion with them. Have you ever thought about weight loss surgery? We have some great bariatric surgeons here at our hospital. You should sit down for a consultation and kind of see, what your options look like.
I think another way it can be handled is just when people do have the bariatric surgery, just start sharing your experiences with your families and friends. And, don't hide it. Don't be ashamed. It's something that's out there that works, that definitely has improved lives and improved health conditions. So as, things are getting better for you, you're losing weight and coming off of medication, share it with your loved ones, with your family members. And if they are interested, and encourage them to go ahead and get the surgery done as well.
I think the ECHO support group is definitely beneficial. I saw a patient a couple of days ago who had sleeve, but talk about surgery in general. I think it comes with discussion, and when patient comes in for an annual visit or visit, obesity got to be on the agenda. Maybe not, every visit, but it got to be on the agenda. And if you know that patient well, I'm talking about specifically men, especially been treating them as an internist for a while, patients what he will do, what he won't do, and the comorbidities. And then at some point, if you tried things, it hadn't worked. Definitely often the surgery is indicated, because how much does it cost to treat, get bypass or stroke or heart failure? I think if you can get them to see that, and especially they're not making progress, I think definitely it's beneficial. I recommended several occasions. And I had as also being a nephrologist, I have a patient who had the sleeve maybe 3 or 4 months ago. He's probably lost about 30 something kilograms now. And I think he got to lose maybe 5 more to be eligible for transplant. So I definitely will offer it. But it's just like he said, it's probably different barriers to overcome in each different patient. And I think we need to definitely have bariatric surgery on the agenda as a treatment option for patients who are morbidly obese, and definitely will, we think will benefit from it, who has failed other measures. Not necessarily failed other measure, maybe need to be part of the treatment plan altogether. In addition to diet, exercise, dietitian evaluation, nutrition evaluations, I think medications, and then, weight loss surgery shouldn't, be a final thing. It may be part of the whole continuum of care in that patient.
I have had a couple people I know that, and I'm not sure if this is like the law of the land or if this is just a practice of this specific location, but here in Mississippi, one of the hospitals, in order to get bariatric surgery, you have to go through a psychiatric examination. And so that has been a hamper for some people. I know they just, they don't even have a mental health condition. They just don't want to go see a psychiatrist.
I think that may be an insurance. Well, I had last patient I had was done at Baptist in Memphis, but I know St. Francis may be part of the whole global weight loss plan to get you certified through your insurance. Okay. Or maybe, they will make sure there's no underlying mental diseases that need to be treated or contributing to the weight loss that's not treated. So maybe insurance related, but I know a lot of programs, even up here does the same, have a mental evaluation. And I had another patient I just saw a couple of weeks ago. She had hers at Baptist and the sleeve, and she was a female, but I think she went through the same thing, a mental evaluation.
Yeah, I think it's part of the evaluation. I think for if they are known as a center of excellence, that's part of the procedure you have to go through. Because I know that sometimes some people view food as the addiction, and oftentimes when they undergo a gastric bypass, they may switch to another addiction, be it drugs or alcohol or something like that. So that's certainly very important to make sure that all of those things are in line as well. And so, gentlemen, as we start to kind of round out and close things out, I think this has certainly been a really great conversation for us to have surrounding men's health. I just want to see if each of you can kind of give us a little take-home point from your perspective as we begin to close out this webinar. And of course, we'd like to keep the options open to be able to invite you all back and have a follow-up later on down the line as far as men's health is concerned. So take home points, gentlemen. Whoever would like to go first.
I'll go ahead and start. I guess my take home point is that men's health is important. And it's not something that we are going to be able to do by ourselves. That I strongly believe that it's going to be an effort by everyone in the family, that mom, sisters, uncles, cousins are going to have to drag their grandfathers, fathers to the hospital and just kind of stay on them. And as we begin to educate the patient, we have to make sure that we educate the family too, so that we can work together to be able to combat some of these risk factors that are higher in the African-American family.
I'll go next. I think one of the things is we gotta make it a priority, meaning that even with African American physicians, the family, look at the African American male and make it a priority. And once we make it a priority, we just gotta keep emphasizing, encouraging them to come if they don't have a regular physician. Even if you do have a regular physician, go to your physician. there's programs and things that have been out there that we don't have to reinvent the wheel. Meaning that, for instance, some joiner had take a loved one to the doctor day. We can do things that already been tried and true that works. Doing things in the barbershop. We can do that once a month. I think we need to, checking blood pressure in the barbershop, giving in literature to the barbershop that African American males go there all the time. So I think making a priority, encouraging African Americans to go to positions, get a position, go to the position, and try to do things in the community to educate African Americans in general and males in particular, that things that we know have worked in the past in other cities, just use those things and try to, improve the healthcare overall. But I think it can be done, no question.
Yeah, it's like two go home points. Speak up and speak out. Speak up when you're around your family members. Make sure that you're telling them these same things. The folks that are out there listening, tell them the same things that we talked about. Decrease alcohol consumption. Make sure you're having a healthy weight. If you have insurance and you have a way to pay for it, go see your doctor every year. Add some years to your life by letting that physician find these problems early rather than late. And then understanding that people will be what they see. So they will emulate what you show them. And so if you go get your vaccination, the person behind you is more likely to get their vaccination. If you go to a doctor every year, they're more likely to go to a doctor every year because they see that it's something that's doable. They see that people are doing it, and they can see the benefits of catching some of these disease processes early.
Yeah, I definitely agree. I think that, for me, one of the things that I will say is just for the men who are on the line, for the women who are also watching, is that, we talk a lot in women's health. We talk a lot about self-care. I think that's important for men too. It's not something that we always talk about, but I think that, we get that the men are out working and kind of taking care of things for the home. But understand that if you're not able to do that, then that is a concern as well. So it's kind of like they tell you when you get on the airplane, put your oxygen mask on first before you start putting the mask on other people. And I think that a lot of our men are putting the mask on everybody else, but then they're passing out. And so it's important that they take care of themselves. And so for us as women, it's important that we stress the importance of that to the men in our lives as well, to make sure that they're getting that appropriate health care. Because I certainly agree with what Dr. Thompson said about how it's kind of a family affair. You have to engage that other person and say, hey, you want him to be healthy. These are the things that we're concerned about if he doesn't handle this issue. So that'll be, the main thing. Make sure it's a family effort. Make sure that make sure you're taking care of yourself, and do it so you can be around for your family for years and years to come. That's the biggest thing. I mean, certainly the reason why we do these types of events is that we want to increase awareness and education about certain topics. And I think that I don't know that I've ever really been on a men's health webinar or really even attended any particular type of men's health education that was geared towards the community. So certainly I think that this is something that's needed. Otherwise, we will have this recording available on our Bluff City Medical Society website. It should be up in a few days. So you can go back and look at this. Again, it's also on our Facebook page, the Bluff City Medical Society Facebook page, and that site is at Bluff City Med. Let me go, because I know some people are visual people, because I am sometimes. I do want to just show that in case anybody wants to be able to screenshot. So that's our social media site at Bluff City Med. That is where you can find us on Facebook, Instagram, and Twitter. And then our website is bluffcitymedicalsociety.org. And so certainly I appreciate everyone joining us. I did just want to circle back and thank our community partners. we certainly appreciate you assisting us with disseminating the information that we have out and encouraging others to attend our webinar. And that's pretty much all we have for the evening. So certainly stay tuned. You can check our site and we will let you know when we plan to have our next webinar that will be posted. But otherwise, everyone have a good evening and thank you for joining us.
Thank you.
Thank you for asking.
All right. So I think that, let's see, stop the sharing. And then as far as the participants, we still have a couple of people on, but that's fine. They're all friends. So thanks, guys. I appreciate you all joining me tonight for this webinar. And then I'll send you guys the link to the recording as well. So let me know if y'all need anything, and I might circle back if we have another men's health event or if there's anything else we may need your assistance on.
All right.
Sure, sounds good.
All right, thank you. Y'all have a good evening.
You too. Thank you. Bye-bye.